to the ADAI Safe Supply webinar. If you see me looking off to the side, I have two screens going, which is what's happening. I'm not looking off into the side. You have my full undivided attention this morning. And I'm Addie Palayew. I'm a fourth year PhD candidate in epidemiology at the University of Washington. And my research focuses on the health and human rights of people who use drugs and epidemiologic methods and thinking. And I'm presenting some of the work that I've done for my PhD and through the summer and on safe supply in Washington State. And after I do this presentation, Dr. Kayla Banta-Green and I are going to take questions about safe supply and the presentation and any other burning questions you might have. So just a few Zoom webinar logistics. Only panelists and hosts can share audio and video. Please put your questions and comments in the Q&A and try to be curious and polite if possible. This can be a really charged subject, and I think we should all at least start with the notion that we come here from a place of wanting to help and wanting to do good, and that we are all at different points along in our journeys, and to be kind to each other. So today, I'm just going to do some quick ground setting. This is just an outline, kind of where we're at and why are we even having this conversation. And then we're going to talk what is safe supply, evidence around safe supply, work being done in Washington, unpacking and discussing all of that, and then we're going to take questions from you people who decided to spend an hour this morning with us. So the context of the overdose crisis and why we're here. Overdose deaths have been increasing at an alarming rate, and change is urgently needed to stop this. Fentanyl is what's contributing to the current surge in overdose deaths in Washington State, as you can see from the graph on the slide. And there's been a large increase in both young and older individuals as the rate of fatal opioids-involved overdose deaths have increased at the purple lines here. But this can also be misleading, as what's often sold as fentanyl powder can be a mix of many substances. So if we look at the other part of the slide, we'll see that the analytical results of a drug test of someone who died of an overdose in Washington State. And not only was there fentanyl in this sample, but there was acetaminophen, which is Tylenol, adazolam, which is a benzodiazepine. There was also cocaine, lidocaine, tramadol, and a bunch of other substances, including methamphetamine. And we can see that this combination of what is being sold is much more than fentanyl. So when we're talking about overdose deaths, it's actually a lot more complicated and nuanced, and the drug supply is changing and evolving. So, but currently our drug supply is where it's at because of prohibition, and we're actually kind of lucky that we just have fentanyl here, and our drug supply is not worse or more fractured. If we look just to the north in Vancouver, Canada, they consistently in their fentanyl also have it with benzodiazepines and xylazine. So while you're just not just managing a fentanyl overdose there, you're also managing a benzodiazepine overdose and an overdose to other things that may not respond to naloxone, so you need oxygen or other tools. And as we move forward, we're not always going to have fentanyl. Like, it is going to pass, and the drug supply is going to shift and change as it did before fentanyl and as it will after. And this made me think about, I was actually recently watching Dr. Kayla Banta-Green testified in front of the Senate Finance Committee on some of the excellent work that he's been doing in Washington State. And when I was listening to the testimony, there was the senior senator from Texas, John Cornyn, the Republican Senate whip. So started talking about how even if we treat everyone, the dangers of the drug supply still remain. And casual users who do not need treatment are still at risk of overdose from the unregulated supply. I personally could not agree more than treatment is vital and needed, but it is not a complete solution on its own. On this, the senior senator from Texas and I are actually friends. However, what I'm about to say next as a solution is probably a little different than what Senator Cornyn suggested, which was further policing of the southern border. My suggestion is this idea of safe supply. So, even though we agreed that the problem is the same, I think what we differ is what solutions do we offer for it. So safe supply is a solution, and is defined and originally by drug users as a legal and regulated supply of mind and body altering substances that traditionally have only been accessible through the illicit market, and was officially defined in this concept document by the Canadian Association of People Who Have Used Drugs, and it's a really good document. I encourage people to read it. That has a lot of really good information in it. So safe supply, the idea, directly reduces the exposure to drugs on the street market for people who use drugs, and this immediately reduces the risk of overdose and has other long-term benefits that we'll discuss. But the idea that they know what is in their drug for potency and purity makes it immediately safer. And the logic is similar to what happened during the regulation of alcohol post-prohibition, where alcohol poisonings dropped precipitously, but we still have alcohol societal problems. So the idea is that providing a safe supply would not solve problems related to opioids in our society, but it would solve the acute poisonings that are currently happening that we're seeing with fentanyl by controlling the amount of active ingredients that's in the substances and providing users with knowledge. Just a note on terminology. You may sometimes see safer supply versus safe supply versus prescribed alternatives to the toxic drug to the unregulated market. There's all kinds of different terms. What I'm going to talk today is about a regulated supply of drugs, and I will be talking safe supply for talking about drug user-led models and safer supply for more medical models. And the reason this comes about is there's a national safer supply community of practice in Canada, and this is a group of physicians who work on safe supply, and they use the term safer supply, and this is what they say. So they acknowledge that the term safe supply comes from the drug user movement. The current medicalized model does not reflect their vision of safe supply. The protocols and policies of current medicalized programs and the types of medications they provide do not adequately or appropriately address the diverse and express needs of people who use drugs. A medicalized model is only accessible to people who are diagnosed as having a substance use disorder, abandoning those who use substances recreationally or intermittently. Because medicalized models do not adequately address diverse needs, people who use drugs must rely on unregulated toxic drug supplies, putting them at risk of drug poisoning and overdose death. Ultimately, safe supply, as outlined by the drug user movement, has yet to be legally realized. For more information about this, they suggest you go to the Kaput Safe Supply document, but they use the term safer supply to acknowledge that the use of opioids always comes with some risk and cannot be called safe. However, safer works to acknowledge that a drug of known quality, composition, and potency is less risky than drugs purchased on the street from an unregulated market. But generally, safer supply is the medicalized models in Canada, safe supply is the general concept, and regulated supply is what I'm going to be using. And a quick note, safe supply and all of this is distinct from decriminalization. Decriminalization is often in the news and it's often confounded with safe supply, but it's very distinct. Decriminalization is about removing legal penalties for people who are in possession of drugs or other infractions related to drugs, and legalization is providing a drug of known quantity and substance. These two can work together to help one another and to make the policies more effective, but they are distinct policies with distinct end goals. Safe supply and treatment. Safe supply is different from treatment, and it's not because the substances that are used produce euphoria, because that's possible in both models. Heroin can be used both in a safe supply model as well as a treatment model. But it's about the context in which they're prescribed, what they're prescribed for, and how does it change and empower the drug user and the end user in terms of ultimate liberation. So the goal of safer supply programs, though, can be very different in some ways, but very similar to treatment in others, and where you draw this line can be very philosophical. But it's not meant to compete with treatment, but rather to complement it. Evidence has shown that those on safe supply are more likely to stay enrolled in treatment, and a recent target trial published in JAMA Network showed that those who access safe supply, who are also on methadone, were stayed in treatment for 45% longer than those who didn't access safe supply. And the important, though, of safe supply is that it's part of the safety net of harm reduction. Here is this continuum of services that's from San Francisco, UCSF, and they have harm reduction, overdose prevention services here, and long-term recovery and medication-assisted treatment over here. And the idea is, coming back from some of the original harm reductions, is dead people don't recover. And so providing a safe supply, even if your goal is to get people on treatment, will keep them alive long enough so that they can get onto treatment. Now, I don't necessarily agree with that framing, but I think that is true, that safe supply is going to keep people alive long enough if they do want to access treatment. And I have friends who are currently on treatment and have multiple months sober and were used safe supply before starting treatment, and now don't use the safe supply anymore. So they definitely aren't meant to compete with one another, but to complement. So the case for a regulated supply. The case for a regulated supply is that there's actually a lot of evidence for this, and that people have shown that this actually really does greatly reduce overdose when it was implemented. I've explained the logic of how it works, and it actually is it's very straightforward. It's not rocket science here. You have something that you know it's in it, and that makes it a lot safer to use. And the question then becomes, how do we access this in a way that benefits society and minimize and as well the health of individuals? And in public health, we love a good U-shaped curve. And that's exactly what I have on my slide. So if we look at the y-axis, we have social and health harms, and on the x-axis, we have liberalization of drug policy with prohibition on the far left, and on the far right, I have unrestricted access. And what we can see is this U-shaped curve is that prohibition, what we're currently doing, and unrestricted access both have a lot of harms. So for example, if we were to legalize opioids and allow it to have like beer style and alcohol style commercials, I would say that that'd probably be a public health disaster. I don't need someone selling me like Vicodins the same way that we sell Bud Light. But throwing someone in jail and disrupting their life is also not a solution forward. And so the conversation today and the conversation around this is, where is that medium where we minimize social and health harms and maximizing public safety? And this graph acknowledges that that's somewhere in the middle between prohibition and full unrestricted access, where there's some regulated control. And we're going to talk about what that can look like today. So there's features that I just want you to think as we go through this that can be implemented in any framework. Licenses for purchasing have been proposed for these models, coupled with mandatory education, similar to driving a car. Signing of a waiver and labeled packages that have health warnings, similar to cigarettes in other countries. And forcing it to pair with harm reduction supplies or co-locate it with treatment services for those who want it and having them available. There are some more heavy-handed measures that you can do. And there is a really good article that talks about this, a public health-based vision of the management and regulation of opioids, that talks about different policy options that we could have depending on how we want to do this, and different levers that we can have, borrowing information from alcohol and tobacco policy where we have been successful in reducing the number of users. So before we also talk into the main framework today, I just want you to open your mind that there's a lot of different ways that this can exist. People have suggested homegrown, where people can grow their own poppies or coca leaves and all of that. If you're a skilled enough gardener, I am not. There's venue-based access, where people have proposed that you could access, for example, drugs like MDMA or other club drugs, but only in specific venues. People have also suggested communal grow, so more like opium cultivation poppy rights, which is also the inspiration for the artwork in the bottom right corner. And there's active work in looking what these different models can look like, including indigenous-led models in British Columbia of how that can look like to have indigenous self-determination incorporated into a safe supply model. So one of the big models I'm going to talk about today is a prescribed supervised model. So this one, depending on where you're at on the philosophical debate, can be viewed either as safe supply or as treatment. And I have grown to evolve where originally I thought this was safe supply, and now I firmly believe that it's in the camp of treatment, but I think reasonable people can disagree of where this is, and there's a lot of nuance to be had. So this is only for people with a prescription. It must be used on site. It's doses that are titrated to someone individually, and there are randomized controlled trials in all the top medical journals from multiple countries that support this, where if you give someone heroin 3 times a day, it is better than methadone. Heroin as a medication for treatment has consistently in randomized controlled trials outperformed or as good as methadone. The same thing for hydromorphone. has been found to be non-inferior, which means as good as in epi language, as heroin, and also other observational studies since then, um, injectable hydromorphone or opioid agonist treatment has been shown to be successful. And this is a model of expanding the treatments and that are available that I think could be promising for Washington State. There's limit, and we'll talk about more of that later. But there's limitations with access and other problems with the substances still being criminalized and the larger general societal problems. This is more of an individualized medical model that works to get people access to different molecules that has been proven to be successful with decades of evidence from other countries, and something that I think, as we'll talk about, should be strongly considered in Washington State. So where we get more into the realm of safe supply is with safer supply, the prescribed unsupervised models. So this is being tried now in Canada with really promising results. So this is, again, only for people with a prescription. It really increased during COVID, but essentially someone can go to their doctor, get prescribed opioids, and take them home with them and then use them how they want. There is less of a medical prescription to it than the prescribed supervised model. You do not need to consume on site. And this was started around 2016 with early pilot programs in Canada, like I said, but really expanded during COVID. And it was really successful. A really large, rigorous studies from British Columbia, which is where the figure on the right is showing from, found that if someone got 1 day of safer supply prescribing, matched to someone with on all these really, basically for confounding not to be an issue, and it's just what's the effect of safer supply, they found that 1 dose, 1 week later, you had a 61% less chance of being dead than someone who didn't receive it. So in epidemiology, we call that all-cause mortality. So you just look at, are you alive or are you dead? And there was a 61% less chance if you received 1 dose. And if you received 4, it was 91% reduced compared to someone who didn't receive anything to the next week. That to me was pretty convincing when I saw this. And this was an analysis that looked at about 5,000 people that were on safer supply and compared them. And that was about everyone who was in British Columbia, and is a very thorough study that uses advanced observational methods as well as uses a rigorous, robust data set that's an entire population of British Columbia's healthcare system. So there's also community-based models. So these ones, the network of people in community, they pull money and they buy from a source. Very different than a medicalized model. One of these was actually running in Vancouver. Some of you may have heard of it. It's the Drug User Liberation Front, DOLF. It's their Dope on Demand program. And so they were selling selling at cost methamphetamine, heroin, and cocaine to people who were in their buyers club. They were mass purchasing it, testing it, and distributing it back out to a very small group of people who they already knew were users. And so in this, they actually published a study, and they found that those who accessed it had a 54% reduced chance of opioid overdose compared to those who were not in their program. And then Allison shared in the chat a link to their site. I encourage people to go look at their evaluation. It's not peer reviewed, but it's very in depth. One of the founders, Jeremy Callahan, is a very talented scientist, a very rigorous quantitative researcher, and as a member, also as someone who does work in a community, this isn't peer reviewed, but it's actually quite. I will personally say that what I said is I was like, this is well done research, at least from my view, from what I've seen. I'm not going to vouch for it, but I would encourage people to go and look at the results because I do find them quite compelling. And it looked at other, not just overdose, but it looked at asking people how much time was returned to your day and all of that, and about reconnecting with family. And some of the responses are really, they're moving. But unfortunately, this is no longer operational right now due to law enforcement activities and is currently illegal. And there doesn't seem to be any appetite federally or provincially at a government level among policymakers for such a model. A dispensary-based model is another model that we're going to be talking about today very briefly. The dispensary-based model is made available without prescriptions in dispensaries like cannabis in Washington. It can be for profit or non-for-profit. There's a lot of ways to do this. One individual tried to start one in Vancouver and was immediately arrested, like within 24 hours. They were not successful, so I don't think, again, there is a lot of I don't think that this one's going to happen anytime soon, but I leave you with the words from the late Dave Poses, who was a writer, poet, harm reduction activist, and says that like alcohol is not legal because it's safe, but it is safer because it's legal. And the idea behind a dispensary model is like if we can't control it, it's like if you can't beat them, you join them, is kind of the idea here. And it's by regulating it, we can make this safer, is the idea of a dispensary-based model. But there's obviously a lot of wrong ways to do this. So where are we at the state of safe supply in Canada? I told you that, there's not appetite for community-based models, and that what I didn't mention, there's actually like a growing right-wing and media backlash in certain places against safe supply in Canada, and has made doing some of this work very hard. And actually, the number of people on safe supply in Canada has peaked and is now decreasing, and has been for a little bit. Despite all of this evidence showing that it has worked, there has been a strong pushback against safe supply in Canada and against harm reduction practices in general, with certain governments trying to focus only on treatment-only models. So the state of safe supply right now in Canada is actually not looking great. And it's not looking great in Canada, we're going to talk more about how right now those same issues would probably just be amplified in the US if we tried something like this here for various reasons. But right now in Canada, the people who are accessing it also aren't just those recreational users we talked in at the beginning. It's people who have diagnosed substance use disorders. So also not everybody who needs it, those like populations we talked about at a risk of overdose, are accessing safe supply in Canada right now. So it may be nice to see that like, hey, safe supply is happening in Canada right now and all of this, and Vancouver is awesome. But in reality, they are also in a fight for their lives. Every inch that you win, they're losing a foot. And people are trying to do, the best that they can while presenting evidence and generating evidence in a scientific manner that's objective and fair. So yeah, that's kind of where things are with safe supply in Canada. And I encourage people, who do want to read more about what's going on. Again, in the International Journal of Drug Policy, Michaud and colleagues, Gillian Cole is the senior author, published a paper mapping a moral panic, is what it's called, in Canada, that really breaks down the current backlash to safe supply in Canada and kind of how this is reminiscent of previous moral panics around drug use that have existed for a century in North America. So that's kind of just setting the ground. Now we're going to go into recent history of safe supply in Washington State, work that's been done here. I have a brief timeline here, and then we're going to go more into some of the details of what the work that's been done in Washington State. So in this brief timeline, so safe supply, first of all, does not exist in Washington State, and it hasn't technically existed since like the late 1890s, early 1900s, whenever Prohibition started. That's the last time that safe supply technically existed in the US. However, safe supply conversations among people who use drugs involved in harm reduction have been happening since pre-2020. I know some of them that were facilitated by some national organizations that were happening in 2020 for toolkits that are being published now. But conversations about safe supply are not novel to the US. It's just putting them in writing and where the moment we're at in Washington State that is new. So Vocal Washington's had informal community conversations with impacted members in 2021. And in this, they were able to inform some of the work on the Overdose Emergency Innovative Recovery Task Force, which was also assembled by Wolfco, Washington, and led to recommendations that safe supply should be part of a community-oriented solution to lower overdose. And as far as I know, this is the first document in Washington that has named safe supply as a solution. Based off of this document and other things, and my PhD, I was able to add some questions to the National HIV Behavioral Survey, which is the 2022 NHBS data collection. And with that, we'll be talking about we'll talk to the data collection that happened there. And from that led to the Substance Use Recovery Advisory Committee meeting, or SURSAC, making recommendations around safe supply, and having a working group. This led to the state legislature funding a working group. Because of this, some of us at ADAI, led by Dr. Banta-Green and I, collected data at ADAI in the summer of 2023 that we'll be presenting today. The data from 2022 ended up getting published in 2024, which was a recent development. And then also recently, the work group had their first meeting. And so what I'm going to be updating you today out of this, what's happened over the last 4 years, is I'm going to show you our study with the NHBS data. I'm going to be showing stuff that we collected from at ADAI in 2023 using similar methodology, and give an update on the Safe Supply Working Group. So, acceptability and anticipated effectiveness of a safe supply of opioids among people who injected opioids in King County, Washington. This was a very exciting paper to work on. And this is the first study published on safe supply in the US. And this was I was really nice to work on this. And it was a large part because Sarah Glick was able to add these questions onto our local National HIV Behavioral Risk Surveillance Survey, NHBS. So NHBS is a study, sorry, I'm just looking for my notes here. So NHBS is a comprehensive system of biobehavioral surveillance. It's been conducted since 2023, and it looks at populations affected by HIV. It happens on a 3-year cycle, and it's men who have sex with men, people who inject drugs, and high-risk heterosexuals. So in 2022, it was the survey around people who inject drugs, and this happens in 19 cities across the US. And there's a core survey that they all need to do, but then there's a local survey where sites can add their own questions. So we were able to add 3 of those questions to the Seattle site, which was really exciting. And just to give you some information, it's also known as, NHBS is also known as the pitch study locally. This study collected data from June 2022 to December 2022. Recruitment was based in Pioneer Square, and it surveyed about 500 people who injected drugs. So the questions that we added are you interested in safe supply? After giving a preamble explaining what it was, yes, no. What models of safe supply would you want? And here are these 4 models that we talked about: prescribed, supervised, prescribed, unsupervised, community-based, dispensary-based. And then we asked, if you asked us safe supply through the model that you said you wanted the most, how would it affect your risk of overdose compared to your current supply? And we asked people a lot more risky, a little more risky, the same amount of risk, a little less risky, or a lot less risky. And so out of those 500 people, 451 people injected opioids. 81%, so 369 of them, wanted a safe supply, which is very high. There was a diverse range of model preferences. Prescribed unsupervised was the most popular, followed by the dispensary model, the prescribed supervised model, and the community-based model was the last one. And if we asked people what they wanted, if they got what they wanted through their model, would it reduce their risk of overdose? 89% said it'd be less risky, 10% said no difference, and 1% said more risky, which was like 3 people out of those 369 said it was more risky. But overwhelmingly, people said that they thought accessing safe supply would really reduce their risk of overdose. And so the takeaway from this is people are really interested in this, or at least who inject opioids. They were interested in a variety of models, and people thought that accessing safe supply through their preferred model would reduce their risk of overdose. But we didn't know, what about people who don't inject, who smoke opioids? And also the granularity for the different models. How interested are people in each individual model one by one? Because we only had 3 questions. We would like to do a bigger survey. and also the expected impact on other outcomes besides overdose. So because of this, we did a follow-on study that was funded by ADAI and led by Caleb, and it's in preparation now. And it was called the Safe Supply Study, and that was where we recruit. And for this one, we recruited people who injected, and then there was a twin study that we pulled the samples, but it was just focused on people who smoked opioids, and that was the Smoking Safe Supply Study. And so in these follow-up studies, we used a similar methodology to NHBS so they could be comparable and similar wording. We asked people who also smoked. We additionally examined all the safe supply models and asked about each one. And we also looked at more outcomes, and we compared it to different expanded treatment models that I'm going to talk about. So for this data collection, we did collection in Seattle, Washington. We collected data from May of 2023 to September of 2023. Recruitment was based in North Seattle at the ADAI office. And we surveyed 351 people who injected drugs and 106 people who smoked opioids. And this here is a map of where we were located. So the 6 models that we asked about were the 4 safe supply models that we asked about before: prescribed supervised, prescribed unsupervised, community-based, and dispensary-based. And then we also asked people if they were interested in expanded methadone treatment, defined as receiving methadone in a clinical setting, where methadone could be started on the same day and you would get an adequate dose. And we also asked about expanded buprenorphine treatment, which is receiving buprenorphine in a clinical setting where buprenorphine could be started on the same day and you would get an adequate dose, which is a form of buprenorphine that is different than low barrier buprenorphine, which does not necessarily have to happen in a clinical setting, which is important to think about when we are looking at these next set of results. And the outcomes that we asked for all of these models, we asked, were you interested in it? We asked the overdose risk in a similar manner using the 5-point scale, a lot less risky to a little less risky. We asked about engagement in criminal activity in a similar way on a 5-point scale from a lot more criminal activity to a lot less, or sorry, a lot more to a lot less. We asked about frequency of use from a lot more to a lot less. We asked about likelihood of starting medication treatment and likelihood of staying on medication-based treatment, depending on whether you weren't on it or if you were on it. So I'm about to present these results to you, and I'm very excited. So here, I'm going to walk you through the graph that we have on the screen. We have 2 outcomes that we're looking at here, which are interest and overdose risk. So on the y-axis, we have proportion or percentages. And on the x-axis, we have models. From the left, we have expanded methadone, expanded buprenorphine, prescribed supervised, prescribed unsupervised, community-based, and then dispensary. And so the first thing that you should be reading is, and then here we have the injecting sample, and then we have the smoking sample. I invite you to only look at the injecting sample for most of them. There is not that much difference between the trends, but I wanted to show them to you for transparency and to show the data. So the first thing that we want to read is, what model are people interested in? And the fastest way to read this is to look at what are people not interested in, which is the height of these gray bars. So what we see immediately is that the majority of people are not interested in expanded buprenorphine, and about 45% are not interested in expanded methadone. And then we go to the prescribed supervised, prescribed unsupervised, community-based, and dispensary-based, where the amount of people who are not interested ranges from, it is more around 25%. So there's a very big difference, which means that the people who are interested in safe supply was about 80% or to the high 70%, where the people interested in treatment for buprenorphine was more around 35% to 40%, and expanded methadone was around 55%. And this was very similar for the smoking sample. But the other thing that's really important to look at here is the overdose risk. So this is the colored part of the bars. And what we see here is that of the people who are interested, the dark purple is people who said that this would be a lot less risky compared to their current supply. The light purple is a little less risky. The white is they say that it's the same amount of risk. The light orange is a little more risky, and the orange is a lot more risky. And what we can see again is that people for all models, including the treatment models, overwhelmingly said that it would be a lot less risky compared to their current supply. And now we go into some more new data. which is criminal activity. And we asked people earlier in the survey, hey, do you engage in any criminal activity? Yes, no. And if to provide for your drug use, we defined it as stealing or boosting to provide for their drug use. And if they said yes to that and were interested in a model, we asked them how would it affect your impact your level of criminal activity. And overwhelmingly, for all models, people said a lot less crime or a little less crime, or the same amount of crime. Most people did not say a little more or a lot more crime. And I think that this is a really important finding and something to show, because I think this is something that people are really interested in, and also something as an outcome when we're talking about drug use in general. And also, it aligns with evidence from Canada that shows that people accessing these programs have reported that they have engaged in less criminal activity to provide for their drug use. And I think this, again, is a very persuasive thing, and I think can be framed as this is a win-win policy solution for a lot of people. Frequency of use is another outcome we asked about, and the dark purple is a lot less use, the light purple is a little less use, the white is same level of use, the orange is a little more use, and the dark orange is a lot more use. And what we can see here is that the treatment models, people overwhelmingly said that they'd be a lot less use or a little less use, and are distinct from the safe supply models where people say more that they would have the same level of use. People do say that they would use less as a group on average, but most people have said same level of use for the different models. And what we can see, at least for the injecting one, is that as the models become more liberated, the same level of use increases as we increase autonomy. And I think this is important to think about when we're thinking about safe supply and treatment, and what is the goal of the person accessing those. And here I think we can really highlights the difference that the goals and the intentions of someone wanting to access treatment are different than when someone is wanting to access safe supply. And we see the same thing with the smoking, where overwhelmingly treatment is different than what the models that were framed as safe supply. We also asked about starting medication treatment. So for those not on treatment, most people said it would have no impact, which I think is fine. But as a group, people said that on average, they would be a lot more to a little more likely, which also lines up with evidence from Canada, which is people accessing this were a little more likely to start treatment. And then also we found the same thing for staying on medication treatment, where people were more likely to stay on it in Canada on average, but there wasn't an impact here. And there are also a group of people in this one where people were less likely, or said they were a lot less likely to stay on treatment. And I caution with interpreting these results as is right now, because there was complicated answers in this, because some people said they'd be less likely because they said, well, if I had access to safe supply, well, I wouldn't need methadone, because they felt like it would meet their needs, and they're using methadone now to meet their needs, which needs to be unpacked and discussed further. But information gained. People preferred safe supply models over expanded medication treatment options. People expected safe supply to reduce risk of overdose across all models. Anticipated they would engage in less crime with safe supply. Expected safe supply would change frequency of drug use differently than treatment models, and believe safe supply would make it more likely on average to start and stay on medication-based treatment. But we just still don't know the acceptability of more detailed models, which care delivery models are acceptable and feasible to people when in more detail, like about medication and dosing schedule and what time do you have to be in the clinic and opening hours, which types of opioids would be acceptable, so heroin versus hydromorphone versus slow-release oral morphine versus fentanyl versus other opioids that could be available for people. Modeling the potential impact of implementing safe supply using advanced microsimulation modeling is something that we are currently working on and is a gap. Implementing pilot versions of certain models to examine their effectiveness in practice, I think, could be a way forward, and I think should be welcomed in Washington State. And similar surveys with stakeholders like policymakers and the public to see where they are at with this, and these policy proposals, I think is also critical if something like this were to move forward. And so findings from Seattle and King County on anticipated behaviors line up with findings from evidence in Canada, as we talked about. And there's a need to model the potential impact in both Canada and the US. And so in the US, the legal context is really hard because right now you can't do any of these models, including the medicalized models, because there are specific laws against it. And short of congressional change or the states or Washington State saying that we want to move forward with this at a wider scale level, anything short of a pilot project right now is currently illegal. And the DEA probably will come after you because it is illegal to prescribe opioids for to maintain an addiction in the US, which is what this would be defined as. So in short, all of these safe supply models in the US right now under law are kind of tantamount to drug dealing. And I would say that only certain exceptions and trying to move this forward, we also need to be thinking about what laws and policies need to be changed to allow for these kinds of policies to be able to be made a reality in this country. And the Safe Supply Work Group is a platform for solutions to be discussed and to discuss these things. So Washington State, as mentioned, has a state-funded Safe Supply Working Group and to examine this exact topic. I am a member of it. And it's unpacking a lot of the questions that we're talking about today. And we've had great presenters to the group, and the group has had ongoing discussions. Allison provided a link in the chat. The meetings are, the public can attend in listening only mode. There's 5 minutes for public comment at the beginning of every meeting, but they are subject to being closed because I don't think it's subject to the Public Records Act. But people are welcome to attend in listening only mode, and I do encourage people to attend as this is a very evolving space that's happening right now. And so we're going to keep on meeting. We're currently generating recommendations, and the final report is due to the governor in December 2024. So in conclusion, safe supply, the evidence shows, reduces drug use risks at an individual level. I don't think that there's much that can be said against that. I think the evidence is very strong. There's potentially less crime with safe supply. I think there needs to be a lot more explored around that. And I think for sure we can say people who inject and use opioids in King County and Seattle are generally interested in this. And there are different models of safe supply, as we've talked about, each with their pros and cons to consider. And as we move forward and think about this, I like the saying that there's a lot of wrong ways that we can do this. And I don't necessarily know if there's a right one, but like implementation moving forward needs to be done very carefully. So I thank you for your time today, for listening. Hopefully that was clear. I welcome your question. Caleb and I now welcome your questions, and thank you.
Great presentation, Addie. This is Allison Newman. I'll just be funneling you some of the questions from the Q&A in the chat. One question in the Q&A that I think is really good nuts and bolts question is, in the Canada model, when a prescription is written, does the individual go to a pharmacy for the prescribed supply to be dispensed?
So for the prescribed and supervised model, absolutely someone can pick that up at a pharmacy. But also in Canada, the medication-assisted treatments are usually dispensed from a pharmacy. So it made sense naturally for all other medications to be dispensed from a pharmacy, because in Canada, there isn't like a structure like an OTP that would be, for example, in the US, the more legally natural entity to dispense these kinds of medications. Such structures don't exist in Canada, so yes, it is all pharmacy based.
Here's a question I thought was interesting, which is, how does the current distribution model of kratom in Washington fit into this discussion?
Well, I would say kratom is an unregulated substance. So there's no regulatory structure for it. And so there's also no health and safety monitoring or concentration or purity or content monitoring of it. So it's essentially an unregulated substance, and that people are accessing that. And we did put out a report on kratom recently. As anybody who's ever driven past a gas station is aware, there's apparently plenty of supply, likely meeting plenty of demand. We're not seeing substantial harms related to it, at least in terms of mortality. And we're also hearing from addiction medicine providers that they're able to care for folks who do use kratom. They do find that folks may be trying to get off of fentanyl are more likely to pass heroin, and kratom has helped with that. It sounds like it's been maybe not as easy a substance, given the high potency of fentanyl, to transition over to kratom. But the structure of it is essentially just something that's completely unregulated.
And we have a question from our colleague Jason Williams, who asks, Addie, you bring up some interesting issues regarding the perhaps arbitrary dividing line between supply and treatment, e.g., prescribed heroin in other countries, why take methadone if you're getting safe heroin, etc. In terms of advocacy, which of course some of us cannot do you think there might be benefits from actually terming safer supply as treatment? It keeps people alive, likely reduces negative knock-on effects, crime, etc., eliminates dope sickness, etc., all of which sounds like treatment.
So I think that's a great question, and I think it's a active area of discussion. And I know a lot of people have suggested this, and I think the short answer is no. I don't think it's helpful. And the reason I think that it's not helpful is that we should be intentional with what we mean by our words. And when speaking to the public, we want to be very clear, because if we intentionally now not miscategorize things or categorize things that are convenient now, they may be harder to explain them down the road when the conversation evolves. So I think being very precise with our language and saying we need treatment, but I like to say that, it's like improv. It's yes and. We need treatment and we need safe supply. And I'm here to scream that we need treatment. I have friends that are on treatment. I think it's really important. But I think they're distinct from safe supply. But I think we can also talk about why people are using drugs, right? So some people use drugs to manage symptoms, such as alleviate dope sickness and all of that, where they could benefit from treatment. So I think having treatment more accessible as well, having also safe supply options, is something that we should strive for. It's something that I'm willing to advocate for. And I think we need both. And by not confusing both, it allows us to more effectively advocate for both.
And interestingly, sort of flipping the question around, at the same time, we're also finding increased awareness and conversations and explicit recognition and permission for looking at treatment medications as harm reduction. So CFR 42 Part 8 that just came out a couple months ago around expanded access and changing of rules around methadone access explicitly acknowledges allowing ongoing use of methadone for people who continue to use substances, and acknowledging explicitly, and they use the term harm reduction as one of the goals for keeping people on medications. Similarly, last year, SAMHSA released a Dear Colleague letter, which is a big deal for them. That's a big policy statement, essentially really acknowledging this low-barrier medications first orientation for buprenorphine without a requirement of counseling. So there's on the flip side, we're also acknowledging the goals of treatment are certainly well beyond abstinence, certainly trying to work towards people's sort of recovery of functioning. So that's where it gets a little messy in terms of the terminology, sort of what are these goals. But I think really to Addie's point, there's plenty of space for both and in this conversation. I'll also acknowledge, I see Samantha Carroll had a note in there about, for the sake of argument, which we love arguments, when we had safe supply with a free prescribing of OxyContin, we still had plenty of overdoses deaths, and that's very true. At the same time, approximately half of deaths involving OxyContin back in the day, 20 years ago, involved OxyContin for which that person did not have a prescription. So while there was a pharmaceutical source, there was also an unregulated way in which people were accessing that substance.
Yeah, and I would also like to touch on that, because I think that is a great point. And I am on the back burner of things to do is a couple of friends and I have to write that commentary of why safe supply prescribing is not, safe supply is not the same as OxyContin. So in the past, there was, I think the importance of safe supply, and one of the underlying things is empowerment and knowledge, which are two things that didn't happen in the Purdue era, where there was intentional misleading of effects and people were misled about how dangerous these are. And people didn't know the risks they were engaging in. And I would say that that's actually the exact opposite of safe supply, where we're trying to advocate for people to know what's in their substances and engage with the risks of them in a way that are healthy, realizing that substances can be neutral and both beneficial and harmful. And taking that approach, I would say, is very different. And then the other argument that I would make is that overdose deaths back then are way lower than they are now. So people were not dying on oxys the same way that they're dying on fentanyl. And there's a lot of people who have said, give me back the oxys over fentanyl. And I'm not saying that we should go back to Purdue Pharma. That is a terrible idea. But providing access to that quality of drug, I think, is something that we are trying to do with safe supply. It's just the policy environment and how we communicate it and how we roll it out is very different than in the. But I think, again, it goes to the point where how we do this, we need to be careful because it can be bad. And there are dangers in what we're doing. And there are bad ways to roll this out. Like I said, allowing Purdue to now advertise, at the end of your workday, have an oxy to relax on TV at the end of the Super Bowl. No, that should not be allowed. So advertisements should not be allowed, which was allowed back then, and other things in the policy environment we can shape can be very different than what we're advocating for now. But we do need to be careful. And I think it serves as a sober reminder of what can happen.
Yeah, thank you for that really thoughtful response. And thank you, Samantha, for bringing that up. Some of the next questions are a little more specific, and you can also say if you're not able to answer them, which is, why did Canada remove easy access to 222s, aspirin coating caffeine, which was regularly available for many decades? Yeah, I thought that might be outside knowledge base. And this is another question, which let us know if you can answer or not. What lessons can we learn from Washington State's former method of regulating cough syrup, signing it at the pharmacy register? Don't know when the state can discontinue the practice or tighten the control. It's okay if that is, I see your confused face.
Yeah, I'm not really familiar with the cough syrup model. I am familiar with the pseudoephedrine model, where just, I think the point, I think an important lesson learned around the concerns around pseudoephedrine 20 years ago being used locally to manufacture methamphetamine, we put that behind the pharmacy counter. But essentially we didn't meaningfully address demand. And so supply and manufacturing moved to a much more efficient place, which wasn't people smurfing and getting pills at pharmacies. It went to large-scale drug trafficking organizations that are very, very efficient and have created a lot of methamphetamine. And there is a lot of methamphetamine out there. And there's also a lot of associated methamphetamine morbidity and mortality. So I think, to me, the lesson learned from sort of the behind-the-counter stuff that was done in Washington State and across the United States is, again, you're squeezing the balloon. You're trying to address the supply side thing without adequately addressing the demand side. So that's, to me, is kind of a lesson learned from that type of policy intervention.
And we have a really nice but broad question. How can someone in the general public get more involved in harm reduction and policy efforts?
Well, one of the main advocacy organizations I will note is Vocal Washington. So that is certainly an organization to look at. And there are other National Harm Reduction Coalition groups. Others you would think of, Addie?
If you want volunteering at a local needle exchange, always you can look up where they are. There's the King County, there's the People's Harm Reduction Alliance, there's the Hepatitis Education Project in Seattle. There's places outside of Washington, but a great way to get involved is always to show up and start doing some frontline harm reduction stuff.
And you're getting a lot of love and support for the presentation in the chat. Thank you, Addie. Love this so much. Wonderful presentation. Addie, this is great across all quadrants. Fantastic presentation, important results. Thanks so much for putting it all together and presenting it here for us.
I would just note, as one of Addie's supervisors and dissertation committee members, their incredible work. And you can tell they are passionate on this topic, but also a great scientist. They've been very thoughtful and very diligent in their work over multiple years to carry out really complicated surveys to manage those surveys, to manage the folks doing those surveys, and then to really be doing really thoughtful data analysis, continually really questioning and thinking about how to do this in a really fair and meaningful way. So I just want to acknowledge Addie's fabulous work on this.
Thank you. And yeah, just on that piece, I just want to say, like, I'm not gonna hide what I feel or where I think. And just on the note of science, I think that we all come with our biases, and it's our goal is to question them, to be like, and to say how those affect us, and then present, instead of striving for objectivity, as Caleb says, striving for fairness, hearing out arguments from both sides. So I have my arguments, but I'm always will hear out someone else's argument and be like, okay, how does this move us forward? And having civil discussions about how do we move ourselves, move as a group forward so that we can save people that we care about.
Yeah, thank you for that. And you're getting so much support and appreciation in the chat. I'll make sure to save this and send this to you. Really a lot of support for the research and for sharing about safe supply. And just so some housekeeping stuff, we'll be posting this recording on stopoverdose.org and also sharing it out. So it'll be on our ADAI YouTube, as well as, we'll share that link. So if there was someone who missed it who wanted to attend, please let them know. And Addie, will you put your email in the chat just so people have it? I know it was on the slide, but in case anyone wants to reach out to you. And just big thanks to Caleb and Addie for presenting today.
Great. Thank you, everybody, very much for joining us. Appreciate it.